In this video, we continue with the Renal System series, starting with Continuous Renal Replacement Therapy. Before we start, be sure to download the free PDF study guide with this video to enhance your learning. The link is listed below. Continuous Renal Replacement Therapy. What is Continuous Renal Replacement Therapy? Well, it provides continuous ultrafiltration of extracellular fluid and clearance of urinary toxins over a period of 8 to 24 hours. This type of treatment is used primarily for clients with acute kidney injury or critically ill clients with chronic kidney disease who cannot tolerate hemodialysis. Just like with hemodialysis, water, electrolytes, and other solutes are removed as the client's blood passes through a hemofilter. Now, because rapid shifts in fluids and electrolytes typically do not occur, hemofiltration is usually better tolerated by critically ill clients. There are 5 variations of CRRT, which you can learn more about on the website. Overall, some that require a hemodialysis machine, and others will rely on the patient's blood pressure to power the system. If CRRT does not require a hemodialysis machine, the client's mean arterial blood pressure needs to be maintained above 60 mm of mercury, and arterial and venous access sites are required. Kidney transplantation. What is a kidney transplantation? It is a human kidney from a compatible donor that is implanted into a recipient. Kidney transplantation is done for irreversible kidney failure. Specific criteria are established for eligibility for a transplant. The patient receiving the kidney, which is known as the recipient, must take immunosuppressive medications for life. The transplanted kidney is placed in the anterior iliac fossa. Usually, the recipient's diseased kidneys are left in place, except for those with polycystic kidney disease, in which the kidneys are often very enlarged and painful. Qualifying donors. Donors may be living donors, related or unrelated to the client, non-heart-beating donors, or cadaver donors. Who are the best donors? Well, the most desirable source of kidneys for transplantation is a living, family-related donor who closely matches the patient. What is a non-heart-beating donor? Non-heart-beating donors are those who have been declared dead by cardiopulmonary criteria and had organs harvested immediately after death. These persons have consented previously to organ donation. The last type of donor is the cadaver donor, which is when they have suffered irreversible brain injury. Let's go over the main criteria for a qualified donor. The physical criteria for donors include absence of systemic disease and infection, no history of cancer, no kidney disease or hypertension, and adequate kidney function. Donors are screened for ABO blood groups, tissue-specific antigen, human leukocyte antigen suitability, and mixed lymphocyte culture index, histocompatibility. Donors are also screened for the presence of any communicable diseases and undergo a complete medical evaluation as well as a nephrology consultation. The donor must be in excellent health, with 2 properly functioning kidneys. The emotional well-being of the donor is also determined. Complete understanding of the donation process and outcome by the donor is important. Then finally, the kidney removal from the donor is done using a laparoscopic procedure. Pre-operative interventions for kidney transplantation. The most important pre-op nursing actions are the following: verifying histocompatibility tests of donors, which will be done by the organ bank personnel, administering immunosuppressive medications to the recipient, maintaining strict aseptic technique, verifying that hemodialysis of the recipient was completed 24 hours before transplantation, ensuring that the recipient is free of any infections, assessing renal function studies, encouraging discussion of feelings of the live donor and the recipient, providing psychological support to the live donor, NHBD or cadaver donor, family, and the recipient. Post-operative interventions. The most important post-op nursing actions and observations are the following. Urine output usually begins immediately if the donor was a living donor. It may be delayed for a few days or more with other donor types. Hemodialysis may be performed until adequate kidney function is established. Monitoring vital signs and for signs of complications such as rejection, thrombosis, renal artery stenosis, or wound problems. Monitoring urine output hourly. Immediately report an abrupt decrease in output. Monitoring IV fluids closely. For the first 12 to 24 hours, IV fluid replacement is based on hourly urine output. Administering prescribed diuretics and osmotic agents. Monitoring daily weight to evaluate fluid status. Monitoring daily laboratory results to evaluate renal function, including hematocrit, BUN and serum creatinine levels, and monitor urine for blood and specific gravity. Monitoring urinary catheter patency. The urinary catheter usually remains in the bladder for 3 to 5 days to allow the anastomosis healing. However, once healed, it is removed as soon as possible to prevent infection. Note that urine is pink and may be bloody initially, but gradually returns to normal within several days to weeks. Monitoring for bowel sounds and for the passage of flatus. Initiate a specific diet and oral fluids as prescribed when flatus and bowel sounds return. Usually, fluids, sodium and potassium are restricted if the client is oliguric. Encouraging coughing and deep breathing exercises. Administering immunosuppressive medications as prescribed. Assessing for signs of organ rejection. Providing the recipient with instructions following the kidney transplantation. Assisting the recipient to cope with the body image disturbances that occur from long-term use of immunosuppressants. Graft rejection. Signs and symptoms, which is a must-know for exams and the Nclex of graft rejection, are the following. Temperature higher than 100 degrees Fahrenheit or 37.8 degrees Celsius. Pain or tenderness over the grafted kidney. 2 to 3 pound, 0.9 to 1.4 kilogram, weight gain in 24 hours. Edema, hypertension, malaise, elevated blood urea nitrogen and serum creatinine levels, decreased creatinine clearance, elevated white blood cell count, rejection indicated by ultrasound or biopsy. There are 3 different types of rejection, which are hyperacute, acute, and chronic. Let's go over each, starting with hyperacute. Hyperacute rejection occurs within 48 hours after the transplant. What intervention takes place when hyperacute rejection occurs? The kidney will have to be removed. Next, let's go over acute rejection. This occurs within 1 week post-operatively, but can occur any time post-transplantation. What is the best intervention for acute rejection? In this case, it is potentially reversible with increased immunosuppressive therapy. The last type of rejection is chronic rejection. This occurs slowly over months to years after the transplant. The best intervention is immunosuppressive medications and dialysis if necessary. Important patient education following kidney transplantation. The following is very important to know for exams. Nurses will be responsible for teaching patients actions to perform and avoid. These teaching points help the patients maintain their transplantation and health. The patient must know the following: avoid prolonged periods of sitting, monitor intake and output, recognize the signs and symptoms of infection and rejection, use medications as prescribed, and maintain immunosuppressive therapy for life, avoid contact sports, avoid exposure to persons with infections, attend follow-up care. Cystitis. Cystitis is an inflammation of the bladder from an infection, obstruction of the urethra, or other irritants. Cystitis is also known as urinary tract infection. It's important to know what types of irritants which are mentioned at the end of the video. What are the most common bacterial causes of cystitis? Well, the most common causative organisms are Escherichia coli and Enterobacter, Pseudomonas and Serratia species. Cystitis is more common in women because women have a shorter urethra than men, and the urethra in the woman is located close to the rectum. Sexually active and pregnant women are most vulnerable to cystitis. Signs and symptoms of cystitis. A patient with cystitis may experience the following: frequency and urgency, burning on urination, voiding in small amounts, inability to void, incomplete emptying of the bladder, lower abdominal discomfort, back discomfort or bladder spasms, cloudy, dark, foul-smelling urine, hematuria, malaise, chills, fever, WBC count greater than 11,000 mm3, 11.0109 per liter on urinalysis, altered mentation, especially with elders. Nursing actions for cystitis. There are a number of assessments, education, and specific actions a nurse has to be aware of, which include the following. Before administering prescribed antibiotics, obtain a urine specimen for culture and sensitivity to identify bacterial growth. Encouraging the client to increase fluids up to 3,000 milliliters per day, especially if the client is taking a sulfonamide, because sulfonamides can form crystals in concentrated urine. Administering prescribed medications, which may include analgesics, antiseptics, antispasmodics, antibiotics, and antimicrobials. Providing heat to the abdomen or sitz baths for complaints of discomfort. Using sterile technique when inserting a urinary catheter. Providing meticulous perineal care for the client with an indwelling catheter. Discouraging caffeine products such as coffee, tea, and cola. Now, for client education, it's important to teach the client to do the following. Avoid alcohol, take medications as prescribed, take antibiotics on schedule and complete the entire course of medications as prescribed, which may be 10 to 14 days, repeat the urine culture following treatment, prevent recurrence of cystitis. Before ending the video, it's important to know the causes of cystitis and how to prevent it. These two topics are frequently asked on exams. Let's go over the causes of cystitis, which include the following. Allergens or irritants, such as soaps, sprays, bubble bath, perfumed sanitary napkins, bladder distension, calculus, hormonal changes influencing alterations in vaginal flora, indwelling urinary catheters, invasive urinary tract procedures, loss of bactericidal properties of prostatic secretions in the male, microorganisms, poor fitting vaginal diaphragms, sexual intercourse, synthetic underwear and pantyhose, urinary stasis, use of spermicides, wet bathing suits, Here are client instructions for prevention of cystitis. Use good perianal care wiping front to back. Avoid bubble baths, tub baths, and vaginal deodorant sprays. Void every 2 to 3 hours. Wear cotton pants and avoid wearing tight clothes or pantyhose with slacks. Avoid sitting in a wet bathing suit for prolonged periods of time. If pregnant, void every 2 hours. If menopausal, use estrogen vaginal creams to restore pH. Use water-soluble lubricants for intercourse, especially after menopause. Void and drink a glass of water after intercourse. So, that concludes this video. Join us in the next video as we continue the renal system, starting with urosepsis. As always, thanks for watching.